So welcome back, guys. This is Dr. Ajinkya here. So as I promised, I'm gonna start YouTube OPD sessions. This is basically to teach you guys, the junior colleagues in ENT who have recently joined MS course, and those who have recently passed MS, or those who have not got a chance to learn much from their respective institutes. Whatever the reason may be, I'm gonna start the OPD sessions. So if a patient comes to your OPD with any complaints in ENT, how you should proceed further clinically, what examinations you need to do, how you're gonna do the endoscopy, what points you should remember to diagnose it properly clinically. Also, I'll be talking about the basic points in radiology, so that if you're supposed to do a CT scan or an MRI for a particular patient, what points you should look for and what could be the differential diagnosis of these cases, and how you can learn and differentiate them on the CT scan to have a good diagnosis. And also, I'll be showing you, if possible in certain cases, the surgical steps and then the histopathological correlation with detailed H&E stain microscopic histopath photographs. So I'll be basically covering the entire thing. So this will help you clear the basic idea. So the first patient, as you can see on the screen, I have a total of 11 cases ready so far. So out of that, this is a first case. Now, generally, you should not jump to a diagnosis beforehand. So this is a patient, as you can see, a male patient, early middle-aged patient. This is a photograph with the eyes covered for legal purposes. And you can see this photograph is showing with a white arrow a white glistening mass in the right side nasal cavity. So this patient had come to me with complaints of right side nasal blockage since a very long time, say for about 1 to 1.5 years. Right side foul smelling discharge, right side nasal blockage, intermittent, but the left side was kind of open, not much problem in the left side. So the patient prominently had the right side nasal blockage, discharge, foul smelling, and right side facial pain, mild pain and tenderness, and also the headache over mild radiating headache over the frontal ethmoidal region. So this was the photograph taken on the anterior rhinoscopic examination, which we first do with just lifting the tip of the nose of the patient. As you can see, this is a very common practice in our OPD, that being residents or being a lecturer or whatever, we normally first elevate the patient's tip of the nose to see what we can see inside the nose. So I could see whitish yellowish glistening mass. If I can just zoom this for you guys, you can see it much better. It is kind of whitish yellow, and it has a shining smooth surface. No, I could not see any discharge at that time, but the patient had a history of the nasal discharge. Left side was completely normal, a bit of deviation of the nasal septum to the left side, and there is no puffiness or swelling on the cheek area. As you can see, the cheek is completely normal in appearance, so it means that there is no edema. And the lips also, you can see the philtrum area, the lip area is free of any swelling or edema or any ulcerative lesions. Also, there was no obvious swelling on the frontoethmoidal region or the eyebrow, no lid edema, no orbital, periorbital cellulitis, nothing like that. So just nasal blockage, nasal discharge, and foul smelling discharge, and a bit of headache on the right side. So this was the clinical profile and the clinical history of the patient, and the duration was about 1 to 1.5 years. Okay, so once you know the complaints, the history of the patient, that becomes the clinical history, and then you should go for the clinical examination, which we normally do with the tip raise of the nose. So this is what we see. And after that, you can take a thericum speculum to have a even better visualization, and you can even go for endoscopy. So the next step here for me was to go for the patient's endoscopy. This is now normally the OPDs have a lot of OPDs have endoscopy facilities there, so we can just decongest the patient's nasal cavity. And after, when I had decongested the patient's nasal cavity, this is what I could see. The nasal cavity at that time was free of foul discharge, but was having a lot of mucoid secretions that time, which I had cleaned. And after decongestion, this is what I could see. Now, If you are thinking at this point that this could be a nasal polyp, could be AC polyp because it is unilateral one side and no other clinical history is present, no bleeding is present. Now there is no history of bleeding, there is no history of any recurrent epistaxis, as I said, so the bleeding is out of the question. So but this mass generally is looking like a reddish, lot of reddish spots are seen with a white, smooth, glistening surface. It could be a late onset juvenile nasopharyngeal angiofibroma. There have been some cases where the patient may get JNA. Very rarely in case of early middle age, I have seen patients getting that. So we should keep that in mind. It could be a vascular mass because it is unilateral. So this is not typically a picture of the AC polyp. It could be if the AC polyp is long-standing and is infected, as a result of which it has a lot of blood vessels inside. So as the patient's duration was 1 to 1.5 years, it becomes a long duration. So this could be an infected nasal polyp, it could be a late onset JNA angiofibroma, it could be any vascular mass because it also appears to be as a form. It's not that, appears to be not that smooth. It has a rough surface but appears to be as firm as well at the same time. So we have to keep all the differential diagnoses in mind. We have to consider that it could be a vascular mass, it could be a hemangioma or behind. So it could be a tumor as well. We never know. Normally young patients, young middle-aged patients do not get tumors unless they have some underlying condition or chronic history. But normally young middle-aged patients do not get malignancies in this age group. And also we could consider it could be something prolapsing from the cranial skull base. It could be a defect in the skull base, something may be prolapsing from it. But we have to keep this in mind only. We should not jump to the conclusion. So the first part is the clinical history and profile is done. Second was the ARS, which is the anterior rhinoscopy, and the endoscopy at the same time. So once we do the endoscopy, the third main step is to go for the CT scan. Now, at this point, still, we do not know what the exact diagnosis could be, but we have a lot of differential diagnosis of unilateral nasal masses. It could be anything, as I just mentioned, few names, the list keeps on going. Okay, so this is not a straightforward case for any junior to understand very easily. So the next thing is that we go for the CT scan. Now, when I had this patient's CT scan done, when I have few photographs, I have a photograph in axial and 2 in coronal in different views. So if you take a look at the axial section over here, if you take a close look at the axial section and the coronal section at the same time, you can see the right side entire maxilla is collected. The entire maxilla is full of opacification. So is the right side nasal cavity is full of opacification, right from the anterior aspect up to the choana right here. So there is a bit of gas shadow over here, air bubbles over here. Could be an infection, could be a sign of anaerobic infection, gas shadows. So it could be secondary bacterial infection, as it is a very long-term complaint, chronic history of nasal blockage. So this is the most important thing if you are considering any malignancy as a differential diagnosis. Well, on the CT scan, it becomes very much sure that it cannot be malignancy because it is a very localized collection in the maxillary sinus, and the entire anatomy of the maxillary sinus walls on the CT scan is completely intact. As you can see, there is no bulge, there is no thinning, or there is no destruction of any anatomy of any bone on the CT scan over here. It is a straightforward collection. Also, if someone is thinking about the differential diagnosis as a capillary hemangioma, or it could be some skull-based lesion which is protruding into the nasal cavity, and then because of the compression could be a secondary polyposis, or sometimes someone may also think of inverted papilloma, but the inverted papilloma look is kind of very different. This is nowhere near the looks of inverted papilloma. So We need to understand the importance of the radiology also over here. So this is simply to me a homogeneous collection, because if someone is thinking of allergic fungal sinusitis, this is definitely not allergic, because you cannot see double density sign over here. I cannot appreciate it very well because you cannot see any other density over here, because this is only a single homogeneous structure in the maxillary sinus coming outside from the OMU and then blocking the nasal cavity over here, as you can see over here as the same. So if I show you the second scan, these two scans are the coronal sections. Over here you can see this is a much more posterior aspect. This is the anterior aspect. You cannot see the maxillary sinus over here. This is near the orbital posterior end. Still, we can see on the right side that the patient's nasal cavity near the area of choana is still having some homogeneous density over here. And nowhere you can see there is any skull-based defect. So this rules out that it could be any encephalocele or cephalocele or anything coming from the cranial cavity. So the entire CT scan is free of that. So any skull-based lesion is ruled out. That is the most important thing. Also, inverted papilloma is ruled out. Allergic fungal is ruled out. Carcinoma is ruled out. Because of the anatomy is completely intact. There's no destruction, not even a single thinning of the bone. You can see lamina papyracea here is intact, the cribriform, the crista gala, everything else is intact. If you are considering it as a juvenile nasopharyngeal angiofibroma, a rare case of a late onset, still you cannot consider this as JNA on the CT scan, because the JNA, now I have done 2 lectures for how to identify JNA on a CT and an MRI scan. So you can go and visit my channel and look for that video, or maybe I can put a link down there. So this is definitely not JNA, because in case of JNA, there will be a posterior wall of maxilla will be having a forward bulge, which I cannot see over here. So because this patient is tilted towards the left side kinda, that is why you can see that this posterior wall and this posterior wall are at different levels. But there is no bulge in the posterior wall of the maxilla, because this is a patient's tilted scan. So that also you have to keep in mind. So there is no Holman-Miller sign here, because it's not JNA. Also, the most important feature which you see in a JNA scan is that near the area of the posterior wall of the maxilla, we can see the spinopalatal foramen, and that in this case it was normal in its width. It was not dilated, so it cannot be JNA as well. So we have narrowed down our differential diagnosis to a very, very limited case. So now I can think of something which is very easy for me. It could be a infected intrachoanal polyp, which is fitting all the criteria in this patient. So it could be an infected AC polyp. And why? Because this also looks like a bit polypoidal, but a bit rough on the surface, which we normally don't see for AC polyps. But it can be seen in cases of infected nasal polyposis because of long chronic standing polyps in the nose. The single mass can get a rough surface and can be a bit reddish because of the infection for a long time. That is a typical polyp known as the infected AC polyp, which can bleed a lot when you are doing the surgery. So now, after all the investigations have been done, your differential diagnosis is narrowed down at the level of the radiology itself. So before doing the surgery, this is why it is very important to have the radiology of the patient, because in case of JNA, the biopsy is contraindicated, or any other vascular mass, we cannot perform the biopsies. It's a strict contraindication. So what I did, I operated on the patient, and by the way, these are like real genuine patients. These are all my patients, so I have a record of them. So when I did a surgery on this patient, I can see that I have the measurements of the mass, and this is the intrachoanal polyp. So judging by the radiology and the operative findings on this patient, this had to be the intrachoanal polyp. Now, intracoronal polyp is the polyp which arises from the maxilla and goes out in the nasal cavity and goes posteriorly into the corona. So they have three parts: the antral part, the nasal part, and the coronal part. Okay, so I have kept it in that order. So the biggest one you can see over here is the coronal part. Because of its straight orientation, as you can see, it's straight. This part represents the one hanging from the corona. Okay, and the one which you can see over here, a bit rough, that is a part of the antral part. That is the antral part. That's the middle part. And then you can see the last one is the nasal part. This is a part which we could see on the photograph of the nasal endoscopy. So if you can just see my cursor over here, I can just zoom in this for you. So you can see this is the typical surface, polypoidal shiny surface everywhere on this polyp. Everything is typical yellowish polypoidal soft, but on the endoscopy we could not see this polypoidal soft tissue because of this particular area over here, which is attached to the polypoidal part. And this was the area which we were able to see on the endoscopy. Now this area is kind of rough, not that smooth as compared. So that was the reason we had to go for other differential diagnosis, because of this surface being being rough rather than being smooth. And as you can see a lot of bloody mucus stuck to the polyp, because these are a lot of infected polyposis. You can actually see a huge area of collection of blood within. This is a typical case of an infected polyposis, which you will not normally see in cases of normal AC polyps. Only AC polyps, those who are very long standing, only in those cases you will see pulling of blood within the polypoidal mass, like this, as you can see on the screen. It's very good to see if you have infected polyposis, bleeds like hell on the surgery. You have to be very patient with the bleeding part, because it's going to bleed like a lot. So, and coming on to the last point, to confirm the diagnosis that it is really actually AC polyp, we gotta have the histopathological confirmation done, right? So as you can see over here, this is the histopathological confirmation, and this is the normal H&E stain. Now this is a zoomed version of the slide, and as you can see over the labeling over here, I have prepared this. This is mentioning that it has got pseudo-stratified columnar epithelium with regular differentiation and regular nuclei. So that's 100 times magnification. That's like really huge magnification. You can see the pseudo-stratified columnar epithelium over here with all the nuclei and the different staining. So the histopathology guy, that's the pathology people over there, they are going to diagnose this. So they are like really important for our surgeons. They help us, diagnose the final confirmation. The second photograph is the same photograph, but in a different field of view, which is actually a 400 times magnification. You can see the labeling over here, it is actually 400 times magnification. You can see the stroma is loose and shows infiltrates of plasma cells, neutrophils, lymphocytes, and few eosinophils. Now, this is very important to understand that histopathologically how you can differentiate between a AC polyp and an ethmoidal polyp. Now the AC polyp, the origin is because of the infection, okay, and the ethmoidal polyp is because of the repeated allergies. So the AC polyp is infective, and as you can see over here, it's only very few eosinophils you can see over here, as depicted by the histopathology department over here. You can see only few eosinophils are seen, but in the case of the allergic polyposis, also called as the ethmoidal polyposis, you're gonna see a lot of eosinophils. So this is a typical presentation of an AC polyp. So this is a full confirmation of how you can actually deal with a patient when he comes to your OPD, right from the beginning, right up to the patient's surgery. So this is how you deal with a patient when he comes to the OPD. Proper A to Z investigations, and you should have proper knowledge of what to investigate and what not to do. Your CT scan, your MRI scan knowledge should be thorough, and I have taken like many lectures on radiological basics. You can just go I have made different folders. You can just select the folder in my library on my YouTube channel, select the folder Radiology in ENT and Skull Base. You will get all the lectures where I have made all the points in radiology very easy for you guys out there. So this is how you deal with the patient, and I hope if you like this video, please let me know. And if you have any doubts in your own OPD, or if you've got any doubts in your own cases in your hospitals, click the photographs. Do let me know. You can reach out my Facebook channel. You can reach out on my Instagram channel. You can reach out on my Twitter channel. So you can reach me anyhow you want. So whatever cases you have, you can discuss it with me. You can clear the doubts, and I'm open 24/7 for discussions. So I hope you like this video. Till then, see you next time. Thank you guys.